Am I audible, sir, clearly?
Yes, yes, very well audible, and everybody is looking bright on Sundays.
Okay.
Okay, okay, Dileep,
But
go.
but I'm not, sir. I'm not looking right. Actually, I'm at in a means in another mood actually.
Okay, what happened? All okay?
Okay, so that's why I just preponed my presentation because of
Oh,
yeah, commitments.
okay.
So my screen is now
It is
visible.
visible. It is visible, Dileep. Just make it a slideshow.
Yeah.
Yeah, go ahead.
So, very good morning to all of you, respected sir, and Dr. Amjad. He is my colleague, and all of you. So, I'm presenting the PCI to LED CTO PCI actually with JCTO score 4. So, in brief summary, he is a 65-year-old gentleman. He was having history of hypertension, diabetes, and he was admitted with accelerated hypertension. On history taking, he was also having a angina on exertion class 2 for last 3 years. ECG showed T inversion in the precordial lead, as you can see, and echo showed distal anterior wall mildly hypokinetic with ejection fraction of 50%. His blood parameters were normal, and this was the angiogram. So, right side it is normal. LCX was also normal, but LAD showed it is 100% occlusion with calcification, evident calcification. You can see where this is the calcification evident, here the calcified lesion, and it was CTO actually. The history way behind for 3 years. So the JCTO score was assessed, and it was 4. There was a blunt cap. There is no beaking or evident calcification was also there. Bending, it has two bend instead of one. It has two bend. One is here and second one is here. So two bend more than 45 degree. Again difficult, and the occlusion length is also more than 20 mm. So the total JCTU score was 4, and difficult category was very difficult. Again, the difficulty was also there because of the two major branches from the CTO segment, one large diagonal and a small septal branch. So they both were even causing more difficulty, actually adding more difficulty. So for this, we 2 days after this angiography, after detailed discussion with the patients and the relative, we proceeded with the three approaches. One, using the dual lumen microcatheter and the direct escalation of the proximal cap. If it fails, then second stage, keeping the inflated balloon at the ostium of the septal branch to direct the wire into the LED. And third one, if direct escalation fail, then the dissection and re-entry was the third choice. It would have been the third choice. Retrograde approach was not possible because lack of the appropriate collaterals. So we proceeded with these three approach step by step. In first approach, we put a filter FC wire into the septal branch, and then proceeded with the help of the crusade dual lumen microcatheter, and directly escalate the pro- proximal cap. But every time the every wire prolapsing down into the septal branch, so it failed actually. So we just proceeded to the second approach. So in that approach, we put a balloon at the ostium of the septal branch, and then escalate the wire directly to the CTO segment. But again, with the help of the fine cross microcatheter. But again, uh, even after using each fielder XT, Gaia second, Gaia third, and Miracle 6, but none worked in that scenario. And each assembly with microcatheter and guide wire, they prolapsed into the diagonal branch. So even after some time, I just switched to the another approach, that was dissection and re-entry. So here, first I inflate that same 2 mm balloon at the proximal cap level, and this technique is called move the cap technique, just to lose the proximal cap. After that, keeping the balloon in same septal branch, we direct the CTO wire into the CTO segment. with the help of fine cross catheter, and uh, we could achieve some lead actually into the CTO segment. So with this was the miracle 6 guide wire that we have achieved this my entry, and then some dye was given through the microcatheter, and it showed that it was in the subintimal areas and subintimal space, and this was the basically where we were at that time, and this called is the Carlino technique, uh, just increasing the space in subintimal area, subintimally. So now we have created subintimal dissection, and space is there. But now the big challenge was how to re-enter without using stingray and crossbows, because we didn't have even we don't have this stingray and crossbows here. So for that I just uh, took another filter XT wire tip, large tip was made, and with some maneuver and difficulty, I could ultimately able to re-enter into the true lumen, and then fine cross microcatheter was uh, went down, even it was went down into the true lumen, and then we rechecked that whether it is really into true lumen or not. So when it was confirmed, then we exchanged the uh, filter XT wire with the all star wire, and then lesion was pre-dilated with 1.5 and 2 sequentially dilatation was done, and then we did the IBUS. IBUS showed heavy calcium. Means calcium, even 270 degree to 360-degree calcium was there in whole segment. You can see in, but cracks were also there because of the pre-dilatation. Mm, so again with the help of IBUS, we again pre-dilated with the 2.5 12 non-compliant balloon at high pressure in whole length, whole segments. After that, it was a even simpler procedure. Synergy 2.75 40 stent was deployed there. Post dilated with again 2.75 12 It was guided by IBUS only, and sequential dilatation was done. And the final run of IBUS showed it well opposed stent, but there was no edge dissection. So this was the final result. Total fluoro time was 68 minute. Radiation exposure was 7.5 Gairi, and total contrast used was 160 ml. This was the final result. Thank you. Thank you very much. So the take home message was CTO PCI is always a challenge in interventional procedure. More than one plan should always be there in the mind during CTO PCI. Move the cap and sideways technique can be used if there is a branch at proximal cap, and one should have a well-equipped well-equipped cath lab and all the instruments in your armamentarium. Thank you. Thank you very much.
Well, thank you, Dileep. This was a tremendous case. This was a tremendous
Yeah.
case. I think this is something very, it requires guts, to continue once you are not entering into the right path from the beginning. And I could see actually your false lumen was a very big length. It was
Yeah.
not a small length false lumen. So, and then you still stuck onto that and kept trying different wires. Tell me one thing, while the false lumen was created by miracle wire, uh, so you pushed your fine cross up till from where try to re-enter into the true lumen. You advanced your fine cross up till that point.
Yes, sir. So we were trying to re-enter into the true lumen, but actually we didn't know where we are. We were actually when Gaia second and Gaia third were they didn't work at all. This is the miracle that worked some did advance up to some extent. So at that level, I just pushed the dye through the fine
And
cross microcatheter, and then we saw the picture.
it was all false lumen. And then you kept your effort on with the Fielder XT, and it took
Filter
some
actually the
time to
large did
re-enter
in
into the
keeping
true
the
lumen.
microcatheter just proximal to just distal to the proximal cap. So the re-entry, I think I made the re-entry through the proximal just after the proximal segment only.
Okay.
So the diagonal that was during the subintimal space, the diagonal which was shown, it was actually means knocked off actually.
No, that's okay. But the image which you showed, it looked like your false lumen was almost more than 2 centimeters.
Yeah, yes, sir.
And then re-entry happened lower down, because after the stenting also there are no branches there.
No branches there
So no
actually.
branches. So it was almost more than 2 centimeter length, which was a false lumen. So true false of 2 centimeter or more, and then true again.
And true,
This
yes,
seems
sir.
to be the situation at in your case.
Yeah,
But
yes, sir.
still, once you get into a false lumen, which is a bigger length, to keep trying with Fielder XT to get into the true lumen, I think this is very bold and a good intervention. Keep trying. So did you check with your echo also to find whether there is any effusion happening or
No,
not?
no, nothing was there. Nothing,
No,
sir.
you keep checking.
Yeah. I kept it checking. Yes.
So very, very bold, very well done. I think this was a tremendous case, and the LED was all viable, it seems, with your last injection. Although almost the stent size, you lost all the branches. So actually, that is all false lumen, but
Yes.
still you made it very well to the true lumen again, down into the LED, and then stented the whole segment. So very
Sizing
good.
was yes, sir. Sizing was done according to the Srivas.
No, very
So
good,
so it
very
looks
good.
actually bigger.
Very good. Anyone wants to add something? Amjad or Ajay Pratap is here.
He can speak without earphone.
Maybe.
Now, I think now it's
Yes.
audible or not?
Yeah,
Yeah.
audible.
I just want to add, sir, that for the re-entry, the polymer jacketed wires are preferable over the Miracle or Gaia 2, like Fielder FC, and for the dissection and then the re-entry. And Pilot is a better option for creating the large lumen, like Pilot 50 or 150, even sometimes 200.
No, very good. Very good. I'm impressed, Dileep. So we give
Yeah.
you a tag of a CTO interventionist. Very
Thank you, sir.
nice. Very nice.
Thank you very
Very
much.
good
Thank
case.
you. Thank you,
So
sir.
I think for the sake of time, we move to the next case.